Welcome to today's special pre-conference webinar about EoE and inflammation. My name's Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. Thanks to our presenting education partners for EOS Connection 2023, Sanofi and Regeneron, this webinar is an opportunity for people at all different stages of their journey with an eosinophil-associated disease to learn new information or get a refresher before diving into content at our annual patient education conference, which is 2 weeks away. We hope to see you in Denver or online on June 30th and July 1st. Today's webinar will focus on how eosinophilic esophagitis works. Now, I'm pleased to introduce Dr. Nathalie Nguyen, a pediatric gastroenterologist at the Children's Hospital of Colorado. Her research and clinical interests are in eosinophilic gastrointestinal disease, including EoE, and innovative methods for disease monitoring, including transnasal endoscopy. Welcome.
Thank you so much, Jennifer.
You're welcome.
Thanks. I just want to thank APFED for the invitation to give this webinar today. These are my disclosures. The objectives today are to learn about the role of eosinophils in the body, discuss how these diseases are categorized, understand how eosinophilic GI diseases are diagnosed, learn about the management and treatment of EoE, and know about the types of specialists who are involved in patient care. I want to highlight some of the sessions at EOS Connection conference that will be in Denver here in a few weeks. There are both in-person and virtual options. I will be discussing the diagnosis of EoE and innovative methods for disease monitoring, such as transnasal endoscopy. Dr. Menard Katcher will be discussing treatments in EoE. Dr. Bauer will be discussing the role of food and environmental triggers in EoE and also shared decision-making. Becky Deutsch, a speech and language pathologist, will be discussing practical strategies for feeding difficulties for patients and caregivers. Kelly Klakowitz and Taryn Van Brennan, our registered dietitians, will be discussing dietary strategies in EoE. Raquel Durbin, a registered dietitian, will be discussing how to navigate the grocery store when you're on an elimination diet. Dr. Adkins will be discussing the role of the allergist in care of patients with EoE. Dr. Jane Robinson will be discussing the importance of mental health in patients with EoE. And there will be lots of Q&A sessions and panels for an interactive discussion. We hope you'll join us for the conference in just a few weeks. Throughout the talk today, you'll see in the bottom corner of the title of talks that will be associated with the topics that I'm discussing that will delve deeper into these areas. Eosinophils are a type of white blood cell that play an important role in our immune system. They are helpful to help us fight off certain types of infections, such as parasites. Eosinophils are named because of the characteristic microscopic stain that gives them a reddish color under the microscope. Eosinophil-associated diseases occur when people have increased eosinophils in certain areas or that tissue in particular. And today we will focus on increased eosinophils in the gastrointestinal tract, particularly the esophagus. The diagnosis of an eosinophilic gastrointestinal disease depends on where the increased eosinophils are found. So in eosinophilic esophagitis, or EoE, the increased eosinophils are in the esophagus. In eosinophilic gastritis, we are referring to increased eosinophils in the stomach. In eosinophilic duodenitis, we're referring to increased eosinophils in the duodenum. Eosinophilic enteritis involves increased eosinophils in any part of the small intestine, including the duodenum, jejunum, and ileum. And eosinophilic colitis involves increased eosinophils in the colon or the large intestine. Today, we'll focus on EoE because it's the most common eosinophilic gastrointestinal disease. Eosinophilic esophagitis is a chronic, allergic, inflammatory disease of the esophagus, the tube that connects the mouth to the stomach. It occurs when eosinophils accumulate in the esophagus. The elevated number of eosinophils in the esophagus can cause injury and inflammation, leading to symptoms of EoE. The symptoms of EoE can vary with age. Young children may present and come to the doctor for more non-specific symptoms, including feeding difficulties, gagging, refusal of certain foods or textures, regurgitation or reflux symptoms, vomiting, a food or foreign body impaction, meaning food is stuck in the esophagus, failure to thrive or poor weight gain, or abdominal pain. In teenagers and adults, we see the more typical presentation of what we call dysphagia. So when I eat, food feels like it's getting stuck or going down slow. People can also present with food impactions, chest pain, reflux or regurgitation symptoms, or vomiting, but these are much less common in adults and teenagers. Some people can develop what we call compensatory behaviors that can make it easier for them to swallow. So some of the questions that we might ask to better understand this include, do you cut your food into small pieces or chew a lot? Do you pocket your food or keep your food in your cheek? Do you need liquid or ketchup or lots of sauces to eat your meals or to lubricate the foods? Do you avoid highly textured foods, or does it take you a long time to eat? The prevalence of EoE is 1 to 4 in 10,000, and 75% of patients with EoE are male. 75% of patients with EoE have other allergic conditions, such as food allergies, seasonal allergies, asthma, and eczema. Dr. Bauer and Dr. Adkins, both allergists, will have talks more to dive deeply into the allergic conditions associated with adults and children with EoE. EoE is the most common cause for food impaction, and it's seen in up to 20% of patients undergoing endoscopy for difficulty swallowing. A gastroenterologist will evaluate patients for symptoms of EoE by taking a careful history. If the symptoms are suggestive of EoE, a gastroenterologist will do an upper intestinal endoscopy. This is usually done on an outpatient basis. During the procedure, the patient is under anesthesia or conscious sedation, and a small tube is placed, called an endoscope, into the mouth. The esophagus, stomach, and the first part of the small intestine are examined, and small tissue samples called biopsies are obtained. Endoscopy with biopsies is the only reliable method for diagnosing EoE. I wanted to highlight a new method for endoscopy that started at the Children's Hospital of Colorado in 2014 in pediatrics called unsedated transnasal endoscopy. Unsedated transnasal endoscopy is where we are able to perform an endoscopy to look at the esophagus and obtain biopsies without anesthesia. It developed out of the aerodigestive program in working with colleagues from pulmonology and ENT who routinely use bronchoscopes to intubate nasal passages in children. Dr. Joel Friedlander wondered if we could go through the nose and into the esophagus like an NG tube or a nasogastric tube. That led to the development of unsedated transnasal endoscopy in pediatrics at our hospital in 2014. We have now performed over 1,000 transnasal endoscopies since 2014, and there are 2 gastroenterologists that perform transnasal endoscopy. Unique to our program, we perform transnasal endoscopy down to the age of 5 years old, as long as children are able to cooperate with the procedure. Patients are asked not to eat and drink for 2 hours before the procedure. They wear virtual reality goggles as a distraction technique. We spray the back of the nose and the back of the throat with a numbing medicine, and they watch a show or movie with the VR goggles. While they're watching the show or movie, we're able to go through the nose into the esophagus with a tiny endoscope. We can take pictures and biopsies. The procedure itself takes about 3 to 7 minutes, and then we're all done. There are no IVs, and patients can eat soon after. There are certainly some limitations to transnasal endoscopy, as not all children and adults can tolerate the procedure because they're awake. The other limitation is at this time, we reach the esophagus and we're able to take pictures and biopsies there, but we can't reach the stomach and duodenum necessarily when we do this endoscopy because of the length of the scope and because patients are awake. In some of the first studies looking at this in pediatrics, we reviewed 190 children and young adults who underwent transnasal endoscopy over a period of 3 years. We performed transnasal endoscopy in children and adults ages 3 to 22 years, and we had a 98% success rate. So out of 300 attempts, we were successfully able to do 294. 54 of our subjects ages 6 to 18 years underwent multiple transnasal endoscopies throughout this time for management of their eosinophilic esophagitis. I will be talking more about transnasal endoscopy and other management and diagnostic strategies at the conference. These are visual findings that we see on endoscopy in patients with EoE. In the top left-hand corner is normal esophageal mucosa, where it's pink and healthy, and you can see healthy blood vessels. In panel B, in the middle of the panel, you can see white exudate or the white flecks in the esophagus. In panel C, you can call what we call esophageal rings in the esophagus. In panel D, you can see furrows. Furrows are these longitudinal lines that run down the length of the esophagus. In panel E, you can see both rings and a stricture in the esophagus. And then finally, in panel F, you can see that even with passage of a scope, some patients can have a longitudinal tear because of a narrowed esophagus. We obtain biopsies at the time of the endoscopy, and a pathologist will analyze the tissue samples under a microscope. If eosinophils are present, the pathologist will count how many are visible. A count of 15 or more eosinophils per high-power microscopic field is highly suggestive of EoE. The biopsies will help make an accurate diagnosis. Pathologists will also look for other signs of EoE on the biopsies. So what does this look like under the microscope? Image A is what a normal esophagus looks like under the microscope. To orient you, in panel B, the top part is the white area is the lumen of the esophagus, or where food would enter. And then next we have the epithelial layer of the esophagus, which is this layer here. And then below that, we have the lamina propria. You can see the small black arrows in the top right-hand corner, and those are pointing to eosinophils throughout this layer of the esophagus. In addition, where the circle is, you can see white areas between the cells that are called spongiosis. The black line is showing what we call reedy peg elongation, where the reedy peg expands up into the epithelium. And the black large arrow here shows the basal layer, or the bottom layer of the epithelium, and that it's expanded upward. Those are the other signs that our pathologists may look at under the microscope. The treatment of EoE involves drugs or medications, dietary therapy, and dilation of the esophagus. I want to highlight the talks by Dr. Manara Katcher on EoE treatment and shared decision-making by Dr. Maureen Bauer at the conference. Topical steroids are one of the mainstays of treatment for many years in eosinophilic esophagitis. The different ways that topical steroids can be delivered are through what we call oral viscous budesonide, where you take the budesonide in a respule and you mix that with a thickener like 5 packets of Splenda, or sometimes we'll use a hypoallergenic formula to make it thick and viscous. The idea of this viscous budesonide is so that when you take it, it slithers down the esophagus to coat the esophagus and treat EoE. The other forms of topical corticosteroids include fluticasone or ciclesonide, which are also topical steroids in the form of an inhaler. What we have patients do is we have them take the inhaler, puff, and then swallow the medicine to coat their esophagus. We typically ask patients not to eat or drink right after so that it doesn't wipe away the medicine. Proton pump inhibitors are also considered a treatment in eosinophilic esophagitis. Some of those include names like omeprazole, lansoprazole, and esomeprazole. In May of 2022, just about a year ago, the FDA approved the first medication treatment for EoE, a biologic called dupilumab. This is an injection that's given once a week and has been used in other allergic conditions like asthma and eczema. Currently, it's FDA approved in EoE for patients 12 years old and up and weighing at least 40 kilograms, or that's about 88 pounds. Again, Dr. Menard Ketcher will speak more about this exciting topic at the conference. The dietary approaches in EoE include elemental diets, test-directed diets, and empiric elimination diets. I want to highlight the talks that will be given by Kelly Klakowitz and Taryn Van Brennan and Raquel Durbin, focusing on dietary elimination strategies in EoE. An elemental diet is when amino acid-based formulas or hypoallergenic formulas are used alone without other foods. It's rarely recommended due to quality of life considerations. Allergy test-directed diets are the removal of specific foods based on allergy testing. That's typically a combination of skin prick testing or atopy testing, but has a low overall efficacy when we look at that alone. Empiric elimination diets refer to the removal of specific foods most commonly known to trigger EoE. The one food elimination diet refers to the removal of dairy. The 2 food elimination refers to the removal of dairy and wheat. The 4 food elimination diet refers to the removal of dairy, wheat, soy, and egg. And the 6 food elimination diet refers to the removal of dairy, wheat, soy, egg, fish, shellfish, peanuts, and tree nuts. Sometimes this is also referred to as the 8 food elimination diet when you think of fish and shellfish separately and peanuts and tree nuts separately. Finally, I want to discuss dilation of the esophagus in the treatment of EoE. This is used if there is an esophageal stricture or narrowing, meaning the esophagus is narrow or there's a decrease in the diameter of the esophagus because of EoE. It does not treat the underlying eosinophilic inflammation, but helps with strictures. The most common adverse event after dilation is chest pain. The complications of EoE that we're trying to prevent with treatment are esophageal strictures, esophageal food or foreign body impaction, feeding difficulties or malnutrition, but we know that EoE in the long term does not cause cancer. The treatment goals of EoE are to diminish symptoms, maintain growth and development, prevent the complications, and balance the risks and benefits of treatment with improvement in quality of life. Many different specialists may work together to be involved in you or your child's care if needed, including gastroenterologists, allergists, pathologists, nurses, dietitians, feeding therapists, psychologists, or other specialists. Some patients may not need all of this specialists, but others may. As you saw highlighted throughout the talk, many of these specialists will be sharing their expertise at the conference. Because of the many specialists involved, some patients are seen in what we call a multidisciplinary clinic. I have the great honor of working in the gastrointestinal eosinophilic diseases program, or the GDP, at the Children's Hospital of Colorado, where we see patients together in the multidisciplinary clinic. In the clinic visit, we have gastroenterologists, allergists, dietitians, feeding therapists, and nurses. And outside of clinic, we work closely with our psychologists, radiologists, pathologists, and researchers. I'm so grateful to work with all these colleagues who teach me new things all the time and help me take care of patients with EoE. So in summary, eosinophils are a type of white blood cell that play an important role in our immune system. The diagnosis of eosinophilic GI disease depends on where the increased eosinophils are found. The diagnosis of eosinophilic GI diseases requires upper intestinal endoscopy with biopsy and histologic assessment by a pathologist. Treatment of EoE includes drugs or medications, dietary elimination, and esophageal dilation. And finally, many specialists may be involved in you or your child's care with the goal of improving symptoms, maintaining growth and development, preventing complications of EoE, ultimately to improve quality of life. I will highlight that there are a lot of things that we understand about EoE, but also a lot that we need to further understand. SEGR is the consortium of eosinophilic gastrointestinal disease researchers, and APFED has a Hope on the Horizon research program. Dr. Fruta will be giving research updates at the EOS Connection conference. Thank you all for attending the webinar today. I hope it was a good introduction to eosinophilic esophagitis. To learn more about the areas I discussed today, we invite you to attend the APFED Patient Education Conference, and you can register for the conference at the APFED website and attend in person or virtually. With that, I'd be happy to take questions.
Thank you so much for the overview and getting people in the mindset and ready for the conference. You know, we're getting some great questions in here, so I'm looking forward to the conversation. All righty. So one of the first things that sparked some questions coming in was your comment about unsedated transnasal endoscopy. Could you share a little bit more about who are good candidates for that procedure?
Absolutely. With transnasal endoscopy, kids are awake throughout the procedure. And I think that, it is not for everyone. I think, patients who would do best with the procedure, we have a video that shares kind of what to expect from a child's perspective. I think the patients who are most successful with it have watched the video and they themselves think they could do it. They'll often watch it with their parents. And then in thinking about that, I think, kids who think they would be able to be distracted while they're watching something and tolerate something down their nose. I think kids who are highly, highly anxious may not be the best candidates, but we do have some kids who, are anxious, but have watched the video and are determined to do it and have been able to do it successfully. I would say that down to the age, we perform transnasal endoscopy down to the age of 5. There are about 17 centers in the US in pediatrics performing transnasal endoscopy these days. Most centers will go down somewhere to the age of 8 or 12. I think the successful 5-year-olds are kids who can follow instructions and who have watched the video and think that they could do it.
So the adults joining us today want to know, is it available or recommended for older populations as well?
Yeah. Transnasal endoscopy has been described across the world in adults, particularly in Japan and other areas. It also is available in the United States. I think we just took a lot of time in thinking about how would we be able to do this in children because they might not be as cooperative as adults. But yes, it is offered in adults. And there was a recent webinar that APFED had on transnasal endoscopy that I would highly encourage you to look at.
Thank you. When people are getting endoscopies done, how often do you recommend it for EoE?
I think that is a patient-specific question. For each person, the care is individualized. I would say that, when we make a change and we want to assess the esophagus to see if there are any changes from that change in treatment, we want people to be on that for at least 2 to 3 months before we anticipate seeing changes in the esophagus.
Okay. You shared information about multiple different treatments that are used for EoE. One of those was elimination diets and looking different things. How do you determine how many foods to eliminate? You showed multiple different models.
Yeah, I think our thoughts on elimination diets have evolved over time as we understand more and more about EoE. I would say many, many years ago, we wanted to remove all of the most likely allergens or most likely triggers in EoE. And as we understand more that the majority of patients have not all of those are their triggers, often some people will work from a 1-food elimination diet and move to a 2-food elimination diet if that is not effective. Again, I think that is patient specific and dependent on what foods people eat a lot of, and that could be contributing or may be a trigger in their EoE. So I think that is a question that is hard to answer generally, but I think for each patient, I think it's understanding what foods they eat a lot of and may trigger their EoE or be a trigger for their EoE, and thinking about what the best approach is, whether that's from the 1-food to 2-food and up, or starting with the 6-food or the 4-food.
Okay.
And I think that has a lot to do with shared decision making also, which is important.
Which will be a good session at the conference. Yes.
Yes, absolutely.
When are PPIs considered for EoE?
Proton pump inhibitors, I would say 10 years ago, were not really considered a treatment for EoE. We actually considered them to be a diagnostic criteria, meaning that in order to say this is EoE, we wanted to rule out reflux through a pH impedance probe or through the trial of a proton pump inhibitor, because these are acid blocking medicines, which we thought were used for reflux. But more and more over the last few years, we've better understood that proton pump inhibitors can actually be considered a treatment in EoE and decrease the number of eosinophils in the esophagus. I think that, again, from a perspective of how I take care of patients, I think that it's an important conversation with families about what the options are and how we deliver the medications, for example, and what their goals are. Because I think proton pump inhibitors are a good, certainly first-line treatment for patients who are newly diagnosed with EoE.
If someone's been on PPIs for a while but has never tried a diet therapy, at what point should they be considering that in collaboration with their care team?
Yeah, I think that is very, very important in the shared decision-making model. I mean, I think when we think about, talking about elimination diets, I think it's important to share what the options are, but everyone's life and everyone's circumstances are different. And that's why it's very individualized I could recommend a 4-food elimination diet or a 1-food elimination diet, but that may be extremely difficult for some people. Some, for example, college students who are going off to college want to be able to eat in the cafeteria with their friends. Certainly, universities will make accommodations for their students, but as a social factor, it may be an important part of their life. And so then I think it's taking all of those things into consideration when we take care of patients with EoE. And so if you've been on a proton pump inhibitor and it works for you and you're happy on that treatment, I think it's a great treatment for EoE. If you feel like you really want to be able to identify your food triggers, I think the timeline of that depends on the patient and when they would be interested in doing that, or if they would be interested in doing that.
So that is very much related to questions we're getting about what foods trigger EoE. Can you comment on the kind of impact or relationship between food allergies and EoE reactions?
Absolutely. So when we think of food allergies are what we call an IgE-mediated response, meaning that when I have that food, you get a histamine release and an IgE response leading to a systemic response, meaning your whole body can be involved. And that's when people have an EpiPen that our allergists will prescribe. Things like hives, difficulty breathing, vomiting, diarrhea. There's lots of different symptoms that you can have from an IgE-mediated food allergy. When we think of EoE, we think it's an food allergy-driven disease, meaning that the ingestion of these foods, certain foods, can over time cause eosinophils to go into the esophagus and lead to the symptoms that we talked about today. So they are different in the mechanism or the way that we think of these foods. And so not everyone who has EoE has a food allergy, and not everyone who has a food allergy has EoE. So they are different in the way that they work.
And so it kind of leads into the question of, do you have data on which food allergies are the most common to cause EoE reactions? But based on what you're saying, it's more about which foods are the most common to cause EoE reactions, because there's not the necessary relationship. Is that what kind of ties back into those elimination diets? Are those 8 foods the most common?
Yeah, so I would say the most common triggers in EoE would be milk, wheat, soy, egg, peanuts and tree nuts, and shellfish and fish. And that's where the 6-food elimination diet kind of started from. And so, the most common by far being milk and then wheat.
Righty, we're going to pivot a little bit to some other treatment questions. We've got one that came in about dupilumab. Given the effectiveness of dupilumab, what is considered failure requiring another treatment modality? Would modality treatment ever be necessary if dupilumab is effective?
Can you repeat the second part of that question, Jennifer?
Sure. Would multimodality treatment ever be necessary if dupilumab is effective?
I think that's a patient-specific question. I think everyone, like I said, is different. I think our goal, or my goal as a physician, is for patients to be on the least number of medications and be on the least restricted diet possible. And so I think if one medication works, then we don't necessarily need multiple medications. But for some people, their EoE may be more complex, requiring that they are on an elimination diet and on certain medications for their EoE. So there are different scenarios for different people. I think that if dupilumab works for someone, then I would say if it works alone for someone, then they may not need the other medications.
Okay. Could you back it up a step for us and just kind of talk about when a care team might consider dupilumab for a patient with EoE?
Yeah. I think this is an evolving area, and because dupilumab was approved just about a year ago, there is lots that we are understanding about the disease and the treatment. I think when I classically think of who would be best for dupilumab, some of those patients that I can think of are ones that may benefit from multiple, that dupilumab may help with multiple diseases. For example, patients who have asthma and eczema and EoE, that they're on multiple different treatments for those different allergic conditions, that dupilumab with one medication may help with multiple things. I also think that patients who are non-responsive, meaning that they continue to have increased eosinophils in the esophagus despite taking their topical steroids, might be good candidates for dupilumab. I think patients who, have tried really hard on different ways to remember to take their medications, but have a hard time taking a daily medication twice a day, or even once a day, if that's how it's prescribed. Dupilumab is a once-a-week injection, so those are other people that may be good candidates for it.
We've got questions about some other treatment options as well. Steroids have come up multiple times as a potential treatment. Could you talk a little bit about the side effects of steroids in children?
Absolutely. I would say the most common side effects that I think of in patients with EoE who are on topical steroids would be oral thrush or esophageal candida. You can have it in the mouth or in the esophagus. I think that occurs in less than 5% of patients. It's a very rare side effect of topical steroids. And so I think, and I just want to take a step back and say, I think of topical steroids very differently from systemic steroids. I think the word steroids can be scary for some patients and families, knowing that EoE is a lifelong disease or a chronic disease. But when we hear the word steroids and we think about long-term side effects, I think people often think of systemic steroids like prednisone or prednisolone, which we do not intend for patients to be on those medicines long-term. When I think of topical steroids, the reason why we call them topical is because we're trying to reach just the area to the best that we can that is getting treated. So for example, with eczema, I would be putting a topical steroid called hydrocortisone on that area of eczema to treat eczema. And so with EoE, the idea of topical steroids is truly to try to coat the esophagus and reach just that area to the best that we can. So the side effects most commonly described in topical steroids for EoE are thrush inside the mouth or the esophagus, which occurs in less than 5% of people and can be 5 to 10% of people, and I would say can be treated with an antifungal medication. The other thing that has been described is adrenal problems, where the body is not able to mount a stress response, a cortisol response, which is what we call adrenal insufficiency. And there are several studies looking at it in different ways throughout the in the EoE literature. And, some of that depends on the way that it's being delivered, the potency of it, and how many different topical steroids you're on, for example, from different allergic diseases like eczema, asthma, and EoE.
So we've got a follow-up question that came in. Are side effects of steroids similar in adults versus children?
I would say they are, yes.
Okay. Please continue.
Oh, that's okay. Go ahead.
You also had some comments about short-term versus long-term. What do you define as long-term use? And specifically, we've got a question about is long-term use okay for a 4-year-old?
I would say that the treatments of EoE, I think, again, the shared decision-making is very important in the management of EoE. When I think of a treatment, I think of, patients are going to be on a long-term treatment for EoE. That doesn't mean that what we choose now means that that's what they'll be on forever. And so that's why follow-up is really important. Discussions are really important, and transparency of how patients feel about their current treatments for EoE. I think in thinking about that, if a patient says, I would like to be on this medication for EoE until my child is old enough to do transnasal endoscopy, for example, that may be a shorter term that they're on certain medications for EoE. But certainly we have patients who have started on topical steroids and are on it for the short term, and they're very happy on it, so they end up being on it for the long term. And I do think that is very safe.
Is there a role for allergy shots in the treatment of EoE?
That is a great question, and I would ask back the question of, do they mean like for treatment of EoE or in the co-management of allergic and environmental allergies, for example?
So they specifically wrote, what is the role of allergy shots in treatment of EoE?
Okay, so I think there isn't a role that we know of currently for the role of allergy shots in EoE, but we certainly, there's a lot of new and exciting information thinking about the role of like oral immunotherapy. And Dr. Bauer will go in depth with environmental allergies and oral immunotherapy at the conference, because it is a hot and interesting topic right now.
Okay, let's see. We've got lots of really good questions coming in here. So a question that they said, sorry if they missed this at the beginning of the talk, but you talked about, can you review again, what is the typical or ideal level of eosinophils and what is the level of someone that has EoE?
Yeah, so in the esophagus, typically someone without EoE does not have eosinophils in the esophagus. When we think of a cutoff, we really think of greater than 15 eosinophils in a certain microscopic field. So we're looking at a certain level under the microscope and counting those eosinophils. When we see more than 15, that's highly suggestive of EoE.
Okay. We're going to pivot the topic just a little bit slightly here, in that we're getting some questions about things lower down in the digestive tract. And so the first one is kind of, does eosinophilia inflammation in the colon or small intestine present similarly to EoE?
So as I mentioned earlier, eosinophilic diseases are really classified by the location of the increased eosinophils. Interestingly, different from the esophagus, in the stomach, the small intestine, and then the colon, we do have normal levels of eosinophils that are resident there and help with our immune system, our GI immune system. And so when we see an increase in the numbers, that's when we consider eosinophilic gastrointestinal diseases besides EoE. And so the symptoms of those really depend on where those eosinophils are increased. So for example, in the colon, when we see increased eosinophils in the colon or eosinophilic colitis, we would expect symptoms of diarrhea, sometimes can have blood in the stool, sometimes can have abdominal pain. When we think of the stomach, we think more of vomiting, abdominal pain, or the most common symptoms of eosinophilic gastritis are in the stomach. And in the duodenum or small intestine, you can have both a combination of those symptoms. You can sometimes have diarrhea, you can sometimes have vomiting, and you can sometimes have abdominal pain. So the symptoms really, when we think about them, really correlate with what area of the GI tract we're thinking of.
Okay. Do you find that there is any coexistence or co-occurrence of EoE and other conditions? For example, one question was about IBD.
There are lots of descriptions of other GI conditions where people have IBD and increased eosinophils in the esophagus. I think some of that is trying to delineate if the eosinophils are, because they're white blood cells and they are part of our immune system, if the eosinophils are from the inflammatory bowel disease or if they're actually from EoE. Because with Crohn's disease, it can involve any parts of the GI tract. So sometimes we can see increased eosinophils as part of our immune system, our complex immune system. We can sometimes see increased eosinophils in the esophagus from Crohn's disease, which is a subtype under inflammatory bowel disease.
Okay. People through their time and experiences often experience flare-ups. Do you find that that means a treatment isn't working, or like what kind of questions are you asking and discussions are you having when a flare-up occurs?
When a flare-up occurs, I think the first question that comes to mind is, have people accidentally gotten an ingestion of, if they're on an elimination diet, have they gotten repeated accidental ingestions of certain foods that would drive those eosinophils into the esophagus? If they're on medication, if they've been good about remembering to take their medicines every day. And then, as I mentioned, Dr. Maureen Bauer will talk more about the environmental role of, or the role of environmental allergies in EoE. But certainly that's something else that I think of.
Okay.
Some people can also outgrow, particularly when we think about pediatrics, we know kids are growing, getting taller, their esophaguses are getting longer as kids, grow and develop. And so certainly at some points, kids can outgrow their current dose of topical steroids or proton pump inhibitors. Not to say that that medicine is no longer effective, but to be thinking about, is it that they're outgrowing that certain dose?
On the flip side, if someone is doing really well and their symptoms have reduced, at what point do you consider reintroducing a food?
Yeah, I think, when patients and families have taken the time to do an elimination diet, I do think it's important to consider endoscopy to ensure that the eosinophilic inflammation has improved, because there's lots of data to say that unfortunately the symptoms of EoE don't always correlate with what we see under the microscope and what we see at the time of endoscopy. And so while we wish that we could rely on symptoms alone, it also is important to have that supportive information of what does the endoscopy look like and what do things look like under the microscope. And so if someone is on a 4-food elimination diet, for example, and they've been on the diet for a period of time, I would recommend or consider an endoscopy to make sure that things are looking good before we start introducing foods. And then I think it's, if things do look good, it's thinking about how do we introduce those foods one at a time. I would say that, with knowing that those top 4 are the most common triggers in EoE, and that's what led to those elimination diets, it's important to understand if the inflammation is under control after introduction of each of those categories of food, because of the fact that, or the data that shows that symptoms, unfortunately, don't always correlate with what we see under the microscope.
Flipping the discussion back to PPIs, there's some questions about if there are any long-term disadvantages or risks to being on PPIs.
Yeah, there's been a lot of data or press on proton pump inhibitors and the long-term side effects. I think, again, it goes back to every person and every patient is individualized, and thinking about their other conditions that they might have and how those potential long-term side effects might apply to each person in their own ways. And so, when we think about the side effects of proton pump inhibitors, I think Dr. Policeman, our catcher, will go over those during her treatment talk. But in thinking about that, it really applies to each patient separately. So, for example, one of the side effects of long-term PPI use may be an increased risk for certain infections like C. diff, which is a bacteria that can cause diarrhea, and it's seen more in people who are hospitalized a lot and are on antibiotics a lot. And so I think, those factors really play a role when we're thinking about patients we're thinking about long-term medication use. All those factors play a really important role in, does this potential side effect even play a role for this person if they're hospitalized a lot, or they've had C. diff before, or they've had recurrent C. diff. So that's just an example, but I think it's really important for us to think about each person individually and when we think about the different treatment options. And that's why that shared decision-making model and individualizing care is so important.
Thank you. Could long-term use of PPIs lead to osteopenia? I'm not sure if I'm pronouncing that right.
I think the jury is still a little out on that. I think we need more information to understand that better. I think one of the ways that we really think about prevention of those things is making sure that patients are on a good amount of calcium and vitamin D.
Let's go back up and find there was one more PPI question while we're talking about PPIs. Alrighty, so there are multiple different PPIs out there. If you try one and it doesn't work, does it mean PPIs don't work, or that you should try a different PPI?
Oh, that's a hard question. I think, when we think about the mechanism of how it works, the different PPIs like esomeprazole or omeprazole, the way that they work are similar. Certainly every patient is different. And so I think if they have a side effect or an intolerance to one, would it be reasonable to try another? Yes, but I don't think they would need to try every single different proton pump inhibitor.
There've been a number of questions coming in about biologics as well. And I know we talked about a little bit about that beforehand. Would you comment on the age at which biologic treatments are considered?
Yeah, so currently at this time, the FDA has approved children 12 years old and up weighing over 40 kilograms. And so currently I would say that is our recommendation based on the studies that have come out and the FDA approval. We know that there are studies for dupilumab in the younger age group, and we should be hearing more about that information and data in the upcoming months, with regard to FDA approval, hopefully, and understanding more of that in the future. But currently, it's approved for patients 12 years old and up. In other indications, like for eczema and for asthma, it is approved much younger, but that's specifically for those indications like asthma and eczema.
Thank you. Just checking to see if there's any more about biologics at the same time. Okay, you talked about the biologics being an injection. For those that are eligible for said treatments, when they get the injection, is there anything that you recommend to make it less painful for the patient?
Yeah, our nurses have been wonderful as we have started dupilumab on patients, working with them to help make that experience better. And so some of the things that they have recommended are using a buzzy bee to help distract that area. They will take out the medicine and let it go to room temperature before giving the injection. And then, some people prefer the pen over the syringes. And so those are all ways that can help the injection be less painful.
You'll have to forgive my ignorance. What is a buzzy bee?
Oh, a buzzy bee is like a little, I don't even know what it's called. It looks like a bee, but it buzzes so that you can put it on your skin. Our nurses will often use it for IVs to start, but it'll distract you, and you can focus a little bit more on the buzzing at another part, and then someone can give the injection, and so it kind of gives you like a sensory, like it buzzes.
The art of the distraction.
Absolutely, it's very helpful.
Oh, alrighty.
I think you can order on Amazon.
There we go. We'll have to take a look at that.
Is what my nurses have told us.
Very good to know. Well, thank you for all your wonderful answers today. I know we've got more questions coming in, and we're hitting up against the top of the hour here. So I really encourage everyone, if you haven't gotten a question answered yet, please come to the conference. Register for EOS Connections 2023 at apfed.org/conference. I'm going to go ahead and spend a couple more minutes talking about that so that we can help get people to join us in Denver. I'm looking forward to seeing you in person in 2 weeks.
Yes, I'm looking forward to seeing you too and all our guests. So thank you so much.
Fantastic. So as we prepare for that, we want to make sure we're thanking you again for your wonderful presentation about EoE and inflammation today. And also thank our presenting education partners for EOS Connection 2023, Sanofi and Regeneron. Their support helped us be able to put on today's special pre-conference webinar. So as we've mentioned many times, in case you forgot, EOS Connection 2023 is in 2 weeks. We are headed to Denver, Colorado, and we will be there for activities from June 29th through July 1st. We'll kick off with some pre-conference activities on June 29th that are specific to being in person in Denver. Then we will have hybrid events, both in Denver and streamed online on June 30th and July 1st. So even if you can't join us live in Denver, please register to access the on-demand content as well as to watch the live streaming content. After the conference is over, all of the content will be available to watch on demand for a full 6 months. So whether you're registering to watch it live or you're registering to be able to watch it later, we have options that you can participate in so many different ways. One of the great benefits of coming to join us live, whether it's virtual or in person, is that you can interact with other patients, other caregivers, other people impacted by eosinophilic diseases. Within our virtual conference environment, there are multiple ways that you can be able to connect with the other participants, be able to have conversations. There could be video chats, there can be text chats. There's just different ways to really, as the name of the conference says, make connections. So we hope you'll all go to apfed.org/conference to be able to learn more. So thank you again for joining us today for this special pre-conference webinar. We know that we didn't get to all the questions that came in today, so please feel free to join the conference and ask the question during the number of different sessions. They're about a variety of different topics. You can also shoot us an email at conference@apfed.org. I hope everyone has a great afternoon.